Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on antiretroviral therapy in pregnancy, featuring Dr. Milena Murray from Midwestern University College of Pharmacy and Northwestern Memorial Hospital in Chicago, Illinois, and Dr. Jonah Musa from University of Jos in Jos, Nigeria. They'll discuss important considerations in the use of ART in pregnancy, including current guideline recommendations, the latest safety and efficacy data, and pharmacokinetic and drug-drug interaction considerations. Following their dialogue, the faculty will field questions from healthcare professionals. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Drs. Murray and Musa.
Welcome to this webinar. So I will start by letting us know that over 90% of the global burden of pediatric HIV/AIDS is accounted by mother-to-child transmission of HIV, which occurs either during pregnancy, that is in utero transmission, or during the events of labor and delivery, and then also in the postpartum period through breastfeeding. And studies have shown clearly that the strongest predictor of the occurrence of mother-to-child transmission of HIV during these three periods is high maternal viral load. Now, prior to the availability of effective combination antiretroviral therapies, the risks of mother-to-child transmission of HIV was occurring among African women living with HIV in about 25 to 40%, if no interventions with ARVs were given. In the US, it was as high as 16 to 30%, and 15 to 30% in Western Europe, and a little bit higher in South and Southeast Asia, in the range of 13 to 48%. Now, with effective combination antiretroviral therapies, these risks could be reduced up to less than 1%, and even much lower if women living with HIV conceived when the viral load is undetectable. So because of this evidence, the World Health Organization has issued a rapid advice to all countries in the world, recommending that effective antiretroviral therapy should be initiated as an emergency among all pregnant and breastfeeding women living with HIV. And this is very important because pregnancy has a gestational period that we have an opportunity to initiate this very effective intervention. Otherwise, we lose the opportunity to prevent mother-to-child transmission of HIV in our population. So what are the benefits of achieving and maintaining viral suppression on effective antiretroviral in pregnancy? Aside the prevention of mother-to-child transmission of HIV that we've already talked about, one of the critical reasons is that you give antiretroviral therapy to optimize maternal health. That is, you are given for her own disease. And one other very important benefit is that it prevents horizontal transmission of the virus to the sexual partner, particularly in serodiscordant relationships. So because of this, ARVs should be administered as soon as we make a diagnosis of a woman who has HIV during pregnancy. To effectively manage these decisions and to use these effective interventions safely for the overall benefit of the mother, as well as preventing the occurrence of mother-to-child transmission of HIV, there are key considerations that clinicians who are confronted with the challenge to manage women in this situation should always keep in mind. There are pregnancy-related factors that must be considered. First among them is the potential teratogenic factors, so the possibilities of harm, that these teratogenic effects of this antiretroviral therapy leading to various forms of congenital malformations should be considered. So we need to know the safety profile of these antiretroviral medications on the fetus and then those who are exposed to it, that is the newborns. And then you also need to have experience or evidence of effectiveness. You have data based on trials during pregnancy. And then pharmacokinetic changes are also important because we know some of the physiological changes that occur during pregnancy may alter the pharmacokinetics, leading to various range of altered effectiveness or availability of the drugs, which my colleague will talk about. And then potential adverse effects also on the mother or during their experience or while they are taking these medications. And then there are some specific individual related factors such as drug interactions with concomitant medications, because we do see this happening, especially when pregnant women are also taking other medications, malaria prophylaxis, especially in Africa, the issue of comorbidities, tuberculosis, hepatitis B, virus co-infections, all those individual factors, we need to look at them. And one important factor, again, you have to choose an antiretroviral therapy combination that has a high barrier for emergence of resistant strain viruses, because if this is not done properly, you now risk the transfer of a resistant viral strain from the mother into the newborn baby, or even horizontal transmission to the partners. And then other factors that must be considered have to do with adherence with the selected or the recommended antiretroviral, and then the issue of convenience. So these are among key factors that we as clinicians should bear in mind when we're making such decisions. And I turn it over to my colleague, Dr. Murray, to carry on from here. Thank you. Over to you, Murray.
Thank you, Dr. Musa, for that great background information. So let's now move into our current recommendations for antiretroviral therapy in pregnancy. So let's start with the DHHS guidelines for therapy. And this table has each drug class mapped by the guideline status. So our preferred NRTIs are lamivudine with bacavir, emtricitabine with tenofovir disoproxil fumarate, or I'll be saying TDF, and then lamivudine with TDF. Our preferred INSTIs are dolutegravir and raltegravir. And then our preferred protease inhibitors are atazanavir boosted with ritonavir and darunavir boosted with ritonavir. Of note for the preferred, both raltegravir and the darunavir should both be dosed twice daily during pregnancy. And any person that's going to be initiating abacavir therapy should have a negative HLA-B5701 test. Dolutegravir we'll be discussing further in the coming slides. And also please note here that the NNRTIs are either alternative therapy or there is also insufficient data for the particular one, doravirine. Bictegravir also does not currently have enough data for a recommendation, and we will be discussing that a little bit later in the presentation as well. And so our listed protease inhibitors here, atazanavir with cobicistat, darunavir with cobicistat, and then lopinavir and ritonavir are no longer recommended due to several factors, including drug levels, tolerability, as well as pill burden. This table lists our INSTIs and protease inhibitors by recommendation for pregnancy if they are therapy naive, and then if a patient has become pregnant while on suppressive and well-tolerated therapy. For the INSTIs, it is recommended to continue dolutegravir or raltegravir, and again, there's insufficient data at this time for a bictegravir recommendation. A switch should be considered in patients taking a regimen with elvitegravir that is boosted by cobicistat. Ritonavir boosted atazanavir, darunavir, and lopinavir may be continued. And if the protease inhibitor is boosted with cobicistat, a switch should be considered. If any of these regimens are not switched, the guidelines recommend an increased frequency of viral load monitoring to make sure that the patient does not become detectable or have a higher viral load. This table has our NNRTIs as well as the NRTIs. And so except for doravirine, the NNRTIs are recommended to be continued in pregnancy. And then in the case of rilpivirine, there should be increased viral load monitoring. And then all of our NRTIs here that are listed may be continued through pregnancy. The WHO recommendations do differ from the DHHS guidelines. So the recommendation here for initial therapy in all adults is dolutegravir plus lamivudine or emtricitabine plus tenofovir disoproxil fumarate, again, TDF. The alternative recommendation is efavirenz, and please note there the dose is 400 milligrams versus 600 milligrams with lamivudine and TDF. They do say we can consider tenofovir alafenamide if the person has established bone disease or they have impaired kidney function. And regarding the concern of neural tube defects with dolutegravir therapy, based on 2 randomized trials, dolutegravir was found to be more effective than NNRTI-based therapy, and the risk of neural tube defects is lower than originally reported, and it should not affect the use of dolutegravir in people of childbearing potential. So do we need to switch therapy during pregnancy if there are safety concerns? Let's look at a case study for this. We have a 23-year-old woman who attends a primary care physician appointment and is found to be 2 months pregnant. Her HIV is well controlled on dolutegravir plus emtricitabine and TDF. She has no other past medical history. So our questions for this patient are, what is the best regimen? Do we need to switch due to safety concerns? Are there safety concerns? What about if the therapy was not tolerated or there was a drug-drug interaction? What can we safely switch to? So let's take a look at some data to answer some of these questions. The Tsepamo study reported the prevalence of neural tube defects based on therapy exposure. The data for 2019 and 2020 are presented in this table, along with the number of neural tube defects by class, dolutegravir, non-dolutegravir therapy, and then efavirenz, and if the person started prior or during therapy. Numbers for those without HIV are in the rightmost column. Overall, the total number of defects reported was low, with only 2 additional defects reported in the dolutegravir group between 2019 and 2020. Based on these and efficacy data, the guidelines no longer recommend avoiding dolutegravir during pregnancy. However, because there is a slightly statistically significant increase in defects, the risks and benefits should be discussed with the patient prior to initiating or continuing therapy. For many years, it was recommended to avoid efavirenz during pregnancy. Based on the results of an observational multinational study, there were no statistically significant differences seen with efavirenz versus non-efavirenz therapy. Data from over 24,000 live births and around 21,000 women were included in this analysis. These data support the safety of efavirenz exposure during the first trimester as well as throughout pregnancy. In areas where dolutegravir is not available, efavirenz is the recommended backbone for the regimen. Data from the French perinatal cohort inform our decisions regarding switching therapy during pregnancy. Over 7,000 pregnancies were included and assessed virological outcomes on those women whose regimens were switched for fetal safety concerns compared to no change on virologic outcomes. In those pregnancies with a switch, there was no risk of a viral load over 50 copies, so a person becoming uncontrolled. Therefore, the authors concluded that therapy switched during pregnancy should occur if there is an intolerance or a safety concern, and that switching the regimen did not have a destabilizing effect on virologic control in this cohort. And with that, I will turn it back over to Dr. Musa.
Thank you, Dr. Murray, for laying that sound pharmacological background and having seen all the options. We will now look at the issues related to initiating antiretroviral therapy, particularly in late pregnancy, to prevent mother-to-child transmission during the three main windows for transmission that we talked about: in utero, labor, and delivery, and through breastfeeding. And I want us to examine this case. And I brought this case mainly to illustrate the constraints that we have in resource-limited settings in Africa. And if you look at this, a 28-year-old primary gravida diagnosed with HIV at 30 weeks gestation in a rural healthcare facility with no resources for CD4 count and viral load testing. No significant past medical history. She lives in a family home with in-laws and not sure of the facility to go to during labor and delivery. And unlike most of you who are out there in the United States and other developed settings, in Africa, this is what happens. Most pregnant women don't book for antenatal care early. So they come to book for antenatal care quite late during pregnancy, and they have all these other problems. So what are the data to support the use of recommended regimens in late pregnancy to prevent mother-to-child transmission? And we have received a lot of information from the last presenter about preferred regimen, alternatives. You know, one of the key things that will guide the selection of the most appropriate antiretroviral therapy here, you have to look at the gestational age at which this was picked. So you have just about 8 to 9 weeks for this woman to go into labor. So you need to pick an antiretroviral therapy that will drive down viral load as quickly as possible. Because if you don't achieve that, and this woman goes to deliver in a facility where they do not have all it takes to prevent mother-to-child transmission of HIV, then you are really exposing that baby to a high risk of mother-to-child transmission of HIV. So having said that, let's look at briefly some trials and data that will help us make the right decision in such a case. So first, we have this data, the IMPAACT 2010 trial, also called the VEST trial, and they look at the safety and efficacy of DTG versus efavirenz and TDF versus TDF in pregnancy. So, and they look at this, that is the efficacy of viral suppression when these 3 different combination ARTs were initiated for the first time during pregnancy. So if you look at the proportion of virological failure by these various combinations, you will find out that the DTG-based antiretroviral therapy, that is DTG plus FTC and TAF, or DTG plus FTC and TDF, had a significant reduction in viral load compared to efavirenz-based combination therapy. And if we look at the statistical analysis here, there were significant differences. So this tells us that if we want to maximize and achieve rapid viral suppression when initiating ARTs during pregnancy, we should go for a DTG-based antiretroviral combination compared to efavirenz. And on that same trial, they also look at safety issues in terms of maternal grade 3 or more adverse events, infant grade 3 or more adverse events, infant deaths, stillbirth, or infant deaths. And if you look at it in all of it, the safest combination ART was the DTG base, particularly if you use TAF rather than TDF. So the TAF FTC combination with DTG was relatively safer compared to FTC TDF or efavirenz FTC TDF. You can see the differences in terms of proportion of these adverse events. So in these 2 arms, when you compare the occurrence of major congenital anomalies, which occurred in 4 infants, so there was atrial septal defect, Talipes equinovarus in the right foot, and then in the efavirenz group, those who were exposed to it, there were incidents of duodenal atresia and ileal stenosis or subgaleal cyst. So again, when you come to the Dolphin trial, actually look at the efficacy of achieving maximal virological suppression if we commence antiretroviral therapy later in pregnancy. And this data actually helps us to answer the decision for that case study that I presented at 30 weeks of gestation. So again, we have talked that you need to drive down viral load as quickly as possible. So if you are confronted with that decision dilemma, this trial has helped us to answer that question. And the endpoint here was achieving HIV RNA viral load of less than 50 copies per mil. And if you look at the hazard of the time it takes to achieve this endpoint between DTG-based therapy and efavirenz-based therapy, you'll find out that those on the DTG base were 2.7 times more likely to achieve this virological endpoint if women were commenced on antiretroviral therapy at 28 weeks or more. And if you look at all the endpoints here, you could find out that efavirenz was significantly, the proportions of attainment of this clinical endpoint was 74% in the DTG-based group compared to 43% in the efavirenz-based group. So this again tells us that the answer to that particular case study that we discussed, we should go for a DTG-based combination therapy because it will drive down the viral load within the quickest possible time compared to efavirenz. So looking at maternal and infant safety, infant transmissions occur in three cases, and they were all in the DTG arm. But again, when they look at the data, most likely these transmissions occur during the window of pregnancy. It was not during labor and delivery or in the breastfeeding period. So that is one caveat we should have. And then the issue of maternal creatinine clearance, baseline to 28-day visit, the creatinine clearance was significantly higher in the DTG group compared to the efavirenz base group. And then the stillbirths that occurred here, there were 3 in the DTG base group compared to 1 in the efavirenz base group. But when they also analyzed the data, all the subgroup analyses, they also found that these 3 stillbirths were unrelated to the ART combination or the immune reconstitution inflammatory syndrome. So in terms of baseline comparability at gestational age, they were all comparable. And then these other outcomes, preterm birth, preterm at 34 weeks or 37 weeks, they were all comparable. And then adverse events and deaths, no significant difference. So the bottom line from that particular study, the Dolphin 2 trial, is that dolutegravir is preferred and recommended as one of the first-line combination ART options for achieving rapid and maximal virological suppression in pregnancy. And this is very important because if women book late for antenatal care, you need to achieve this objective for you to be able to reduce risks of mother-to-child transmission of HIV in labor, delivery, and during breastfeeding. One other thing I talked about in that case study is that woman is living in a family home with in-laws, telling us that the issue of not breastfeeding the baby is almost going to be impossible because in Africa, mother-in-laws usually will come home and they will want to insist that they should feed their grandchild. So if you look at all those things, it's better you choose a combination antiretroviral that will achieve that virological endpoint as quickly as possible. So I won't go into much details about this, but the antiretroviral pregnancy registry just helps us to track women who are exposed to ARVs compared to those who were not exposed. And then we look at all these endpoints and we can come up with safety of these antiretrovirals. So, and 2 of those registry of note, we have the Metropolitan Atlanta Congenital Defect Program, and then we also have the Texas BATS Defect Registry. And if you look at them as the reference registry here, for the TBDR, the pool effects in terms of adverse effects is around 4%, about 4.1%. And then the Metropolitan and Atlanta Congenital Defect Program, the pool effects is close to 3%. And if you look at it all, this gives us the various estimates of risks, for lamivudine down to, all the antiretrovirals. And if you look at the DTG here, this is the safety profile. And so this registry helps us to track the safety of all the various combination antiretrovirals that are needed. And it will help us to make informed decision when we are counseling patients for this. And with that, I take you back to Dr. Murray to give us more information on pharmacokinetics of AR reagents in pregnancy. Thank you. Over to you, Murray.
Thank you again, Dr. Musa. So we are going to switch directions and talk a little bit more about the pharmacokinetics of antiretrovirals during pregnancy. First, let's discuss general pharmacokinetic changes during pregnancy. We typically think about changes with absorption, distribution, metabolism, and excretion. Absorption is affected by delayed gastric emptying and reduced small intestine motility during pregnancy. The gastric pH is also increased, and of course, patients may experience nausea and vomiting. These can lead to a lower maximum concentration and a longer time to maximum concentration, as well as reduced bioavailability. For distribution, there is an expansion of both intra and extravascular volume, decreased maternal albumin binding, and beta-alpha-1 acid glycoprotein. Hormones may also be displaced from albumin. These all lead to an increased volume of distribution for hydrophilic agents and an increased free fraction of drug for the mother and the fetus. Metabolism affects our enzyme inhibition and induction by the hormones estrogen and progesterone, as well as cholestasis that can be caused by estrogen. These lead to variable effects on drug metabolism and a decreased biliary excretion of drugs. Finally, there is an increase in renal blood flow and glomerular filtration, which leads to an increased clearance of medications that are renally eliminated, as well as a decrease in the steady state concentrations of those drugs. So how do these pharmacokinetic changes during pregnancy affect antiretrovirals? And then how do we manage those changes and that may occur? For atazanavir, concentrations are reduced in pregnancy, and if given concomitantly with TDF or an H2 antagonist, the concentrations of atazanavir are decreased even further. So we like to increase the dose to 400 milligrams as recommended in the second and third trimesters. It should be noted that the package insert actually recommends this change for those people taking also TDF or an H2 antagonist. However, most clinicians will choose to increase the dose for all patients. For darunavir, we should be using this twice a day at the 600 milligram darunavir with 100 milligrams of ritonavir, and this should be taken with food. Lopinavir ritonavir should be dosed twice daily and not the once daily dosing. And it also should be increased to 601 of lopinavir and 150 of ritonavir in the second and third trimester. And this does cause a quite high pill burden for people. And then for rilpivirine, the area under the curve or AUC and trough are lowered by up to 50%. However, there are actually no recommendations to increase the dose. If this agent is used, more frequent viral load monitoring is recommended. When we look at our protease inhibitor regimens here, so any regimen that is boosted by cobicistat is not recommended during pregnancy. So our elvitegravir and cobicistat concentrations are reduced during pregnancy, and higher doses have not been studied. So there is insufficient data to recommend a dose in pregnancy since higher doses have not been studied. Atazanavir trough concentrations are reduced 80 to 85% lower than those seen in non-pregnant adults. And with darunavir and cobicistat, it is only available as a fixed dose combination and is not recommended to be given more than once daily. So we would not use this during pregnancy. Additionally, there have been reports of viral rebound in the second and third trimesters associated with the cobicistat boosted regimens. Dolutegravir and raltegravir do not need any dose adjustments during pregnancy. As previously noted, raltegravir should be given as the twice daily regimen, and the once daily high dose formulation should not be used during pregnancy. And again, to date, there is not enough evidence with bictegravir for its use during pregnancy. However, as I say that, there were some data that were just presented So while the guidelines don't recommend it because of the insufficient safety and efficacy data, the PANA study that was just presented on bictegravir pharmacokinetics in pregnancy, we have 2 patients from this study. So the first patient, the concentrations of bictegravir were lower when compared to postpartum concentrations. However, the trough concentration was above the protein-adjusted 95% inhibitory concentration. And then for the second patient that was presented, there was a maximum concentration of 4.84 milligrams per liter that was seen. And because of all of this, the authors indicated that the cord blood to maternal blood ratios indicated that bictegravir does cross the placenta. Both women were undetectable in the 3rd trimester, and both babies were healthy and had negative HIV DNA PCRs. So hopefully more data to come on bictegravir. In our last few minutes, we will be discussing common drug interaction considerations during pregnancy. The following slides have antiretrovirals and drug interactions with commonly used agents in pregnancy. So you can see that there's going to be a box for each drug and concomitant medication combination. So if it is green, there is no interaction expected. Yellow would be a potential weak interaction. Orange is a potential interaction, and then red would mean do not co-administer. In general, there are no expected interactions with NRTIs and the agents that are listed in the following slides. So for our multivitamins, iron and folate, there are potential interactions with dolutegravir and raltegravir. It is recommended to separate these agents from the INSTIs or to take together with food. This slide lists antacids, H2RA antagonists, and proton pump inhibitors. So for our antacids, there are potential interactions for all agents except ritonavir-boosted darunavir and efavirenz. Atazanavir and rilpivirine have a potential interaction with famotidine, cimetidine, and ranitidine. And then proton pump inhibitors should not be co-administered with atazanavir or rilpivirine. For drug-drug interactions with malaria prophylaxis, there are no expected interactions with sulfadoxine pyrimethamine. Mefloquine has a potential weak interaction with rilpivirine and a potential interaction with ritonavir-boosted atazanavir or darunavir, as well as efavirenz. And chloroquine has a potential interaction with ritonavir-boosted atazanavir and rilpivirine, and a potential weak interaction with ritonavir-boosted darunavir or with efavirenz. So in summarizing all this information, all pregnant patients should be offered therapy to maintain maternal health, prevent vertical transmission, and prevent transmission to partners. There are data to suggest safety and efficacy of several regimens for recommendation both early and in late pregnancy. Pharmacokinetic changes should be considered and guidelines consulted for any changes in doses that may be required. And then drug-drug interactions should be assessed between antiretrovirals as well as any other concomitant medications the patient may be taking. I did want to say that there is one additional resource too that can be considered. There's the National Clinician Consultation Center Perinatal HIV Hotline or Warm Line. And this is a resource for clinicians who have questions about antiretroviral therapy for people who are pregnant or who are considering pregnancy. And more information can be found at their website. The phone number is 888-448-8765, and they can be reached 24 hours a day and 7 days a week. So a great resource there for those that may have additional questions. With that, we are going to go ahead and move into our question and answer session. If you do have a question, please feel free to go ahead and put it in the question box. I'm going to turn it over to Dr. Musa to discuss our first question from Rodney, which is breastfeeding is not recommended by the DHHS guidelines, but does the WHO recommend a dolutegravir-based regimen for those who are breastfeeding?
Thank you. Thank you very much, Dr. Murray. And that question is from Rodney. Sorry if I'm not able to pronounce the name correctly. That's a great question, and it's a great concern. But the data that we have, and that is what the WHO is basing their recommendation, is that though DTGs levels are found in the plasma of neonates and young infants that are being breastfed by mothers who have DTG. It has been shown, safety data has been shown that it does not pose any side effects or risks to those babies that are exposed to it. And based on that, for a very long time, the guidelines and the WHO guidelines actually recommend that DTG-based regimen should be given to women, even those who are breastfeeding. And this is particularly important in Africa, where we have a very stringent proviso for not breastfeeding. So the issue of accessibility, feasibility, affordability, safety, and sustainability of breast milk substitutes. So to just summarize your question, or the answer is that yes, it is recommended. Thank you.
Okay, and we have time maybe for one quick question. Dr. Musa, I'll allow you to answer this as well. This is from Colin. Are there any studies for pre-exposure prophylaxis for infants to decrease viral transmission during breastfeeding?
Yes, there are studies. The earlier studies on this were based on nevirapine and zidovudine, either short exposure and long-term exposure. And some of these trials were done, some in Botswana, and those data have shown that you give the nevirapine and then you cover the nevirapine tail with either lamivudine and zidovudine or zidovudine alone, just to really prevent the emergence of nevirapine resistant viral strain in those infants that are exposed to it. So those are the studies that we know about. So in terms of pre-exposure prophylaxis, we know about nevirapine, we know about lamivudine and zidovudine therapy, either short-term or extended pre-exposure prophylaxis. Thank you.
Thank you to Drs. Murray and Musa, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.